Usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Right, like engineering almost.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the attending just points at the screen and says, well, there it is.
Yeah, it's binary. The bone is broken or it isn't. It's clean. And frankly, I think it's comforting. We really like things to be visible and easily categorized.
Oh, for sure. But then, you step into the world of pediatric dermatology and trauma, and suddenly that x-ray machine is just broken. We're looking at a diagnostic landscape that is entirely clinical, visual, and honestly, a bit murky. You can't just scan for a rash.
You really can't. It is the absolute definition of diagnostic muddy waters.
Yeah.
You are relying entirely on progression, distribution, and a really solid understanding of the underlying pathophysiology.
Right. And that is exactly why we are here today. Welcome to today's deep dive. If you are listening to this right now, chances are you are a nursing student gearing up for your ATI RN Pediatric Nursing Proctored exam.
And if you are, seriously, take a deep breath. You are in the right place.
Yeah, today's mission is to crack the code on pediatric integumentary disorders. We are taking the core concepts from chapters 30, 31, and 32 of your ATI text and reframing them. Because, and this is huge, pediatric skin is not just small adult skin.
Absolutely not. It is a highly sensitive, dynamically changing organ. It requires entirely different protocols than adult dermatology.
Okay, let's unpack this. Here is our clinical roadmap for this deep dive. We are going to start by looking at what happens when the skin gets attacked from the outside, your infectious invaders and bugs.
Which is chapter 30.
Right. Then we'll pivot to what happens when the skin's own barrier compromises from the inside, kicking off inflammatory rebellions like dermatitis and acne.
Moving right into chapter 31.
Exactly. And finally, we will tackle the absolute catastrophic structural destruction of burns.
Which is a perfect progression, really. From localized surface invaders to total systemic collapse. Treating a toddler's skin like an adult's isn't just incorrect, it can actually be life-threatening.
Wow, yeah.
So my goal today is to help you synthesize these massive subject areas into test-ready clinical aha moments. Because, memorizing a list of symptoms won't save you on a proctored exam. Understanding the why behind the nursing interventions is the key to passing, and more importantly, the key to safe practice.
I love that. So let's start with those outside invaders. Whenever I see a practice question that includes the phrase, honey-colored crusts, immediate alarm bells go off in my head for impetigo contagiosa.
Oh, absolutely. That's the classic buzzword.
Clinically, you see this very distinct progression, right? It starts as reddish macules, erupts into vesicles, and then forms those classic sticky crusts. Since it's caused by Staphylococcus, the standard protocol is to jump straight to a topical bactericidal or like a triple antibiotic ointment.
Yeah, the topical application is your first-line defense because the infection is superficial. But the why behind your nursing education here is crucial. Impetigo spreads through direct contact, and the exudate beneath those crusts is highly infectious.
So it's not just about healing the current sores.
Exactly. You aren't just applying an ointment to heal it. You are actively trying to prevent the child from auto-inoculating other parts of their body when they inevitably scratch it.
Because kids are going to scratch.
Always. For severe systemic cases, oral or parenteral antibiotics might be necessary, but managing that topical spread is your absolute priority.
Makes total sense. Now, what about the viral invaders? We see verruca, which are just standard warts caused by the human papillomavirus. But the really highly testable one is HSV1, right? The herpes simplex virus type 1, which causes cold sores.
Yes, cold sores are incredibly common. They typically appear near a mucocutaneous junction, so like the lips or the nose. They start as a localized group of vesicles that itch and burn.
And then they crust over.
Right, they dry out into a crusty area followed by exfoliation. And for exam purposes, remember the entire healing process runs about 8 to 10 days.
Got it. 8 to 10 days. And since it's viral, you're largely managing symptoms and letting it run its course while preventing secondary bacterial infections. But let's move from bacteria and viruses to fungi, specifically the tinnias.
The ringworms.
Yeah, you've got tinea capitis on the scalp, corporus on the body, curris for jock itch, and pedis for athlete's foot.
What's fascinating here is a highly specific, easily testable detail regarding the transmission of tinea capitis and tinea corporis.
Oh, I know where you're going with this.
Yeah, when you are educating a family about treating ringworm of the scalp or body, you don't just treat the child's environment, you must instruct them to treat their infected household pets. especially cats.
I love that detail. Treat the cat. It's such a specific nursing intervention to remember for the exam. But staying on the topic of things you can catch, let's look at the creepy crawlies, the bites and
Oh,
infestations.
the fun stuff.
Right. The two heavy hitters you have to differentiate clinically are scabies and pediculosis capitis, which is head lice. If a child comes into the clinic constantly scratching, how do we pull these two apart?
Well, it's all about the pathophysiology of the bug itself, which dictates the visual evidence you'll see. Let's look at scabies first. The scabies mite doesn't just sit on the skin.
It burrows, right?
Exactly. The female actually burrows deep into the stratum corneum to lay her eggs and deposit feces. This triggers a massive delayed type IV hypersensitivity reaction.
Wow. Okay.
So the hallmark symptom is intense, maddening itching, especially at night when the mites are most active. Visually, you are looking for thin, pencil-like barrel marks on the skin.
And that looks a bit different in babies, doesn't it?
It does. In infants, because they have thinner skin, you might see widespread pimples on the trunk or blisters on the palms of the hands and the soles of the feet.
Okay, and because they are physically burrowed deep into the tissue, the treatment protocol is pretty intense. You apply a 5% permethrin cream over the entire body, but you have to leave it on for 8 to 14 hours. I always wondered why it takes so long.
That's the key. The neurotoxin in the permethrin cream needs time to physically seep down into those microscopic tunnels to actually reach the mites and their eggs.
Oh, so if you wash it off too early.
The eggs survive, exactly. If you wash it off in 2 hours, you fail. You leave it on for that 8 to 14-hour window, wash it off, and then usually repeat the treatment in 1 to 2 weeks to catch any newly hatched nymphs.
Okay, now contrast that intensive process with head lice.
Right, so pediculosis capitis is a completely different beast.
Yeah.
The adult louse doesn't burrow. It lives right out in the open on the scalp, feeding on blood.
So no burrow marks.
None. The key visual finding isn't a burrow mark, it's the presence of nits. These are tiny, white egg casings firmly cemented to the hair shaft near the scalp.
They kind of look like dandruff, right?
They do, but if you try to brush them away, they don't flake off. They are cemented on. Because they are on the surface, the treatment is a 1% permethrin shampoo left on for just a few minutes, followed by meticulous removal of the nits with a fine-tooth comb.
1% for lice, 5% for scabies. That's a great distinction. Now, the environmental protocols for both of these are rigorous. You wash everything the child has touched in hot water. But for items that cannot be laundered, like a favorite stuffed animal, the ATI protocol is wild.
It really is.
It's essentially a 14-day timeout. You place the unwashable items into a sealed plastic bag for 14 days.
It's an excellent analogy, the timeout. And there is a strict biological reason for that 14-day window. The adult louse can only live up to 48 hours without a human blood meal, so those die quickly in the bag.
But the eggs are the problem.
Right. The nits take 7 to 10 days to hatch. So that 14-day sealed bag ensures that every single egg hatches, and then the resulting nymph immediately starves to death before it can ever touch the child again.
That is incredibly thorough. Before we move on from outside invaders, we have to mention two specific bites that show up in pediatric trauma. First is Lyme disease from ticks. The protocol is to observe the child for 30 days after the bite, looking for that classic erythema migrans.
The bullseye rash.
Yeah, exactly. If confirmed, they need a 2 to 3 week course of antibiotics. But then there's the brown recluse spider bite. The pathophysiology of this venom is just terrifying.
It is severely destructive. The venom contains powerful enzymes that physically liquefy cellular membranes.
Liquefy. Yes.
The bite site progresses to a star-shaped purple area within 3 to 4 days, indicating severe ischemia, and then turns into an open necrotic ulcer in 7 to 14 days. It requires immediate, aggressive medical attention to prevent massive tissue loss.
Okay, so we've dealt with the bugs, the fungi, the venom, all these things attacking the skin from the outside. Let's pivot to Chapter 31. What happens when the skin itself rebels? When the barrier breaks down due to an irritant, moisture, or a genetic predisposition?
This is where we see the child's own immune and inflammatory response kick into overdrive.
Right, the inflammatory rebellions, dermatitis, and acne.
Exactly. And often these immune responses cause more damage than the initial trigger.
Let's start with contact dermatitis, like poison ivy. The immediate nursing intervention is incredibly straightforward, right? Cleanse the exposed area with cold running water as soon as possible to wash away the urushiol oil, followed by a soap and water shower.
Yep. Get the oil off fast.
But diaper dermatitis is where the clinical logic feels a bit backwards at first glance. We use a skin barrier like zinc oxide to protect the irritated area. But the ATI text clearly states we are not supposed to wash the zinc oxide off with each diaper change.
Which trips a lot of students up.
It does. If a baby has a soiled diaper, my instinct is to scrub that area completely clean. Why wouldn't we do that?
I completely understand why that feels counterintuitive, but clinical reasoning dictates otherwise. Think about what diaper dermatitis actually is. The stratum corneum has been macerated by moisture and chemically burned by the ammonia in urine and enzymes in feces.
So it's essentially a chemical burn.
Yes, the skin is highly inflamed and structurally compromised. If you vigorously scrub off that thick, sticky layer of zinc oxide with every single diaper change, the physical friction of your wipe will literally tear away the healing layer of the epidermis.
Oh, wow. So you are creating microabrasions that worsen the dermatitis.
Exactly. You gently cleanse the soiled areas, but you leave the intact barrier ointment alone and just apply more on top.
Just layer it on.
Right. You also want to allow the buttocks to air dry whenever possible to reduce that moisture maceration. And here is a major safety warning for your exam. Absolutely avoid talcum powder.
That's because of the inhalation risks.
Precisely. Talcum powder contains ultrafine particles that can cake and cause severe, life-threatening inhalation injury and chemical pneumonitis in infants. It has no place in pediatric skincare.
That is a massive safety flag to highlight. Now, let's briefly touch on seborrheic dermatitis, which most people know as cradle cap. The treatment here is gentle mechanical removal. You massage the scalp with mineral or vegetable oil to soften the thick, yellowish crusts, and then use a fine-tooth comb to gently lift them away.
Very gentle, yes.
But atopic dermatitis, or eczema, is a much more complex chronic barrier issue.
It is, and eczema presents very differently depending on the age of the child. This is a classic test question for nursing students.
How so?
Well, in infants, the distribution is typically generalized. You see lesions on the cheeks, the scalp, the trunk, and the extensor surfaces of the arms and legs. But as the child grows and their motor skills change, the presentation shifts.
They start moving more.
Exactly. By age 2, children tend to get these lesions in the flexural areas, the folds of the skin. So you are looking at the antecubital fossa inside the elbows, the popliteal fossae behind the knees, and the neck.
This raises an important question. The fundamental problem with eczema is transepidermal water loss, right? The skin just can't hold on to moisture. So how do you properly hydrate this constantly dry, intensely itchy skin?
The ATI text gives a very strict protocol for this, and it's all about timing. You use tepid baths, perhaps with a mild soap or emulsifying oil, but the critical nursing intervention happens the second the child gets out of the tub. You must apply an emollient within 3 minutes of bathing.
The 3-minute rule. Why the rush?
Because the tepid bath temporarily hydrates the outer layer of the skin. But because their skin barrier is defective, if you don't apply an emollient immediately, that water rapidly evaporates into the air.
Leaving it drier than before.
Exactly. Leaving the skin even drier and more irritated than before the bath.
Yeah.
The emollient literally locks the water into the tissues.
Makes perfect sense.
Also, you must gently pat the skin dry, do not rub it, as friction triggers the itch-scratch cycle. And dress the child only in soft cotton clothing. Absolutely avoid wool and synthetic fabrics, which trap heat and cause extreme pruritus.
That 3-minute rule is a fantastic, highly testable detail. All right, let's talk about the ultimate teenage rebellion of the skin, acne.
Ah, yes.
The primary culprit here is the overgrowth of Propionibacterium acnes inside blocked follicles. There are several medications to manage it, but they come with very specific lifestyle and nursing instructions. For instance, benzoyl peroxide.
A very common one.
Yeah, I remember this from clinicals. It's a powerful antibacterial, but it comes with a huge lifestyle warning for teenagers. If they don't wash their hands thoroughly after applying it, they will permanently bleach their pillowcases, towels, and favorite shirts. Interestingly, it doesn't bleach the skin, but it will absolutely destroy fabric.
It's a very practical patient education point, but the clinical education points really ramp up with tretinoin.
Oh, yeah.
Tretinoin is a topical retinoid that interrupts the abnormal keratinization causing those microcomedones.
Yeah.
However, it can be intensely irritating. So the specific nursing instruction is to have the adolescent wash their face and then wait 20 to 30 minutes before applying the medication.
Wait a full half hour. Why wait that long?
Because applying a potent retinoid to damp skin dramatically increases its absorption rate. The water on the skin acts as an accelerator, pulling the medication deep into the tissue way too quickly.
Which causes a reaction, I assume.
Right. It results in severe erythema, burning, and peeling. You wait for the skin to be bone dry. Then you apply just a pea-sized amount at night because the medication degrades in sunlight.
Okay, now we need to talk about the nuclear option for severe cystic acne, isotretinoin. The monitoring required for this medication is intense.
It has to be. Isotretinoin is highly teratogenic, meaning it causes severe catastrophic birth defects. The prescribing protocols are incredibly strict.
What are we looking at for test prep here?
If the client is a female of childbearing age, she must use 2 forms of effective contraception for 1 full month before treatment begins, during the entire course of treatment, and for at least 1 month after treatment ends.
2 forms of birth control. That is a massive exam point, and because it's an oral systemic medication, there are other major adverse effects to monitor, right?
Yes. You must draw blood to monitor for elevated cholesterol and triglycerides, which can spike dangerously. And crucially, you have to monitor the adolescent for severe behavioral changes, including depression and suicidal ideation.
Wow, so it's a full systemic monitoring.
It is a highly effective, life-changing drug for severe acne, but it requires rigorous interprofessional oversight.
Okay, we've looked at surface irritations, at localized infections, and at systemic barrier inflammation. But now we have to move to chapter 32 and talk about total structural obliteration. What happens when the skin's integrity is completely wiped out in seconds? Let's talk about thermal injuries and burns.
This is where pediatric physiology truly diverges from adult physiology in terrifying ways. A burn in a child is not just a localized wound, it's an immediate systemic threat.
Here's where it gets really interesting. The text notes that children under 2 years old have a significantly higher mortality rate from burns than older children or adults. Why is a toddler so much more vulnerable to the exact same thermal exposure?
It comes down to structural immaturity and a complete lack of physiological reserves. Infants and toddlers have significantly thinner skin than adults.
So the damage goes deeper faster.
Exactly. A spill of hot coffee that might cause a painful but minor superficial burn in an adult will burn right through the dermis of an infant, causing a deep partial thickness or even full thickness injury.
And their bodies just can't handle the shock.
Right. Furthermore, infants have decreased glycogen and protein stores, and their renal and immune systems are largely immature. When a massive systemic inflammatory response is triggered by a burn, their tiny bodies simply do not have the metabolic capital to manage the massive fluid shifts, maintain core temperature, or fight off the inevitable bacterial colonization.
That makes perfect clinical sense. Before we get to the systemic shock, let's quickly review the stages of burn depth, because the visual assessment is highly testable. First degree is superficial. It's pink or red, no blisters. Think of a standard mild sunburn. Second degree gets tricky because it's divided. Superficial partial thickness has blisters, and it blanches, turns white when you press it. But deep partial thickness is red or white and does not blanch.
Correct. The lack of blanching is your clinical indicator that the capillary bed in the dermis is physically destroyed. Blood can no longer flow in and out of that tissue.
Then you have third degree, which is full thickness. The skin looks leathery, it can be black, brown, or red, and there are no blisters because the moisture is entirely gone. Finally, fourth degree is deep, full thickness, extending all the way down to the fascia, muscle, or even the bone. It looks dull and dry.
And the most shocking clinical finding about a fourth-degree burn: the patient will report no pain in the deepest part of the wound.
Because the nerve endings themselves have been completely incinerated.
Exactly. The surrounding first, second, and third-degree tissue will be agonizingly painful, but the fourth-degree epicenter is completely numb.
Let's talk immediate nursing care. A child presents with a minor burn. I feel like everyone's grandmother has a home remedy, usually involving putting ice or butter on it. But the text explicitly says, do not use ice.
And this is where we really have to correct the grandmothers.
Yeah.
Ice causes severe immediate vasoconstriction.
Which cuts off blood flow.
Yes. You are taking tissue that is already dying from thermal injury and actively choking off its remaining blood supply. It dramatically worsens the tissue necrosis.
So what do we use instead?
You use tepid water. Run cool water over the injury, or use tepid water soaks to stop the burning process. You also avoid greasy lotions or butter, because those lipid layers actually trap the heat inside the tissue. Cleanse it gently with mild soap and water, apply an antimicrobial ointment, and cover it with a non-adherent dressing.
But a major burn is a completely different scenario.
Oh.
This requires a specialized burn center. Because, like you said, a major burn isn't a skin issue, it's a vascular issue. I like to think of the vascular system in a burn patient like a soaker hose.
A soaker hose, yeah.
The moment that thermal injury happens, massive inflammatory mediators are released, and the capillaries lose all their integrity. They become incredibly porous.
If we connect this to the bigger picture, that soaker hose analogy is perfect. Fluid, plasma proteins, and electrolytes violently leak out of the vascular space and pool in the interstitial spaces.
This causes massive visible edema, right?
Yes, but more importantly, it leaves the vascular system entirely empty. This triggers profound hypovolemic shock.
So while the first step is always airway, administering 100% humidify oxygen, the second step is what actually keeps them alive. Massive fluid resuscitation via a large bore 5e. Walk us through this specific fluid protocol.
Timing is everything in burn resuscitation. For the first 24 hours of burn recovery, you infuse isotonic crystalloid solutions, like lactated ringers.
To replace the sheer volume lost.
Exactly. You are frantically trying to replace the sheer volume of fluid and sodium pouring out of that soaker hose. Then, after 24 to 48 hours, when the capillary permeability finally begins to seal up and stabilize, you switch to colloid solutions like albumin or synthetic plasma.
Because the albumin acts like a sponge.
That's a great way to put it. Albumin is a large protein molecule. By infusing it into the vascular space, you increase the oncotic pressure, which literally pulls the leak fluid back out of the swollen tissues and into the bloodstream where it belongs.
And how do we know if this massive fluid resuscitation is actually working? We strictly measure urine output. The ATI standard here is very specific, right?
Extremely specific.
For a child weighing under 30 kilograms, you want to maintain a urine output of 0.5 to 1 ml per kilogram per hour. For a child over 30 kilograms, you maintain a flat 30 ml per hour. If they aren't hitting those numbers, you are losing the battle.
Precisely. Urine output is your most reliable, non-invasive window into their hemodynamic stability. If the kidneys aren't producing urine, it means they aren't being perfused with blood. It means your fluid is still leaking out and the child is still in shock.
This brings us to pain management, which just has to be aggressive in a major burn. The text highlights IV morphine, fentanyl, or midazolam, but here is a critical contraindication that will absolutely trip someone up on an exam. The text specifically says to avoid IM or subcutaneous injections for burn pain. Why is that?
It goes right back to that hypovolemic shock we just discussed. In a major burn, the body is desperately trying to protect the brain and the heart. It shunts all available blood away from the skin, the fat, and the skeletal muscles.
I see.
Yeah, so if you inject a dose of morphine into a muscle or subcutaneous tissue, it will just sit there. There is no blood flow to pick it up and carry it to the brain.
So the child remains in excruciating pain.
Right. And worse, a well-meaning nurse might administer a second or third IM dose, thinking the first wasn't enough. Then, hours later, when your fluid resuscitation finally works and peripheral blood flow is suddenly restored.
Oh no, they all hit at once.
Exactly. All three of those pooled IM injections will be absorbed into the bloodstream simultaneously, leading to a massive, potentially fatal respiratory depression overdose. Intravenous administration is the only reliable, safe route for pain medication in a major burn. And always pre-medicate before any wound care or debridement.
Wow, that is a huge clinical safety point. As the child stabilizes, we have to be hypervigilant for infection, especially if they receive a biologic skin covering, like an allograft. The skin shield is gone, so bacteria have a free pass. What are the signs of graft infection we need to watch for?
Systemically, you are looking for an unstable body temperature, so either spikes or sudden drops. But locally, at the wound bed, you are watching for subchar hemorrhage, which is active bleeding beneath the scab or graft.
And there's a specific color change too, right?
Yes. You are looking for a very specific, dangerous visual cue, a green discoloration of the subcutaneous fat. That vividly indicates a massive bacterial colonization, highly likely to be Pseudomonas aeruginosa.
Finally, wound healing requires massive metabolic energy. The child is literally rebuilding an organ. The text calls for a high-protein, high-calorie diet, heavily supplemented with vitamins A and C to promote collagen synthesis, and zinc to facilitate cell division and growth.
The metabolic rate of a pediatric burn patient resting in a bed can be twice that of a healthy child running around a playground. They will physically consume their own muscle mass for energy if we do not artificially supply them with enough enteral calories and proteins to rebuild that lost tissue.
Okay, let's take a breath. We have covered a monumental amount of ground today. from battling outside invaders like scabies mites and contagious impetigo, to protecting the compromised skin barrier with the 3-minute eczema rule, and navigating the severe teratogenic risks of acne medications.
A lot of material.
It really is. And finally, we broke down the incredibly intense systemic pathophysiology of major pediatric burns, the massive fluid resuscitation, the strict urine output parameters, and the absolute necessity of IV-only pain management. So, what does this all mean for your exam?
I want to leave you with a final thought to mull over as you continue your test prep. We started by saying pediatric skin isn't just a wrapper. It is the child's primary shield against infection, their main temperature regulator, and their essential fluid barrier.
It's doing so much work.
Exactly. When a child's integumentary system is compromised, whether by a burrowing mite or a fourth-degree burn, their entire systemic balance, from hemodynamics to immunity to renal function, teeters on the edge of a cliff. As you study these disorders, remember that in pediatric nursing, treating the skin literally means treating the whole child.
I love that. When the X-ray machine is broken and the diagnostic picture is murky, you have to look at the whole system to find the answer. To the nursing student listening to this, you have put in the work. You now have the underlying logic and the clinical reasoning to conquer this material. Best of luck on your ATI RN Pediatric Nursing Proctored exam. You have the knowledge to absolutely crush it.